everyone, and welcome to today's webinar presentation, Working with Neurodivergent Families, a Strength-Based Approach. My name is Sarah Carsley, and I'm an Applied Public Health Science Specialist at Public Health Ontario, and I have the pleasure of co-moderating today's session. Before we begin today's presentation, I would like to acknowledge and respect the lands, sky, and waters of Ontario, including for their contribution and sharing to support all life within. I acknowledge and respect the treaty, unceded, and traditional territories of all First Nations across these lands and waters. I would like to acknowledge that I'm in Toronto on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, and the Haudenosaunee and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. I acknowledge that Toronto is covered by Treaty 13, signed with the Mississaugas of the Credit, and the Williams Treaties, signed with the multiple Mississaugas and Chippewa bands. Please join me in acknowledgement and respect of all Indigenous peoples, their life journeys and worldviews. May their wisdom always guide our own paths forward with open hands, open hearts, and open minds for the mutual success and benefit of all in Ontario. Lastly, I would also like to acknowledge Daniel Coles, who helped co-author this land acknowledgement, and thank him for sharing it with us. I'll now mention a few housekeeping items. To enhance the presentation experience, participant audio video has been disabled. The chat pod has been disabled to limit any distractions during the presentation. Please use the Q&A pod if you have questions during the session. A discussion and question period will follow the presentation. If at any point during the session you experience any technical issues, please email capacitybuilding@oahpp.ca. I'd now like to introduce my co-moderator for today's session, Dr. Sue Jack. Dr. Susan Jack is a professor in the School of Nursing at McMaster University. Over to you, Sue.
Great, thank you so much, Sarah. I'm really thrilled again to be here with you today, as well as everyone who's joining us from around the province and the country, and to be co-moderating with you and representing the work of the PHN Prep team, where our goal is really to support public health nurses, supervisors, managers, home visiting staff, and other community-based clinicians in their work with families, with individuals who are pregnant or families with young children. Over the last year, as we've had opportunities to speak to public health nurses who work with families, what we've learned is that nurses have shared with us that they have resources and information on how to work with young children who experience a range of neurodiversities. Yet what continues to come up as questions from nurses is, how do we work with parents who are neurodivergent? And how do we support neurodivergent parents in their process of parenting and engaging with their young children? So given that these questions came up, I was really pleased and excited to be able to connect with some of my colleagues at McMaster University and Hamilton Health Sciences who agreed to come and share their wisdom and expertise with us today. So it's really my pleasure to introduce our three speakers for today's presentation. Dr. Terry Bennett and Dr. Natalie Razzo are child and adolescent psychiatrists at McMaster Children's Hospital. And Dr. Bennett is one of my colleagues and a researcher at the Offord Center for Child Studies. And she's also a member of the McMaster Autism Research Team. And Dr. Razzo specializes in inpatient and medical psychiatry and clinical quality improvement. And they both share an interest in family-centered care and the mental health of neurodivergent children and families. And it's also my pleasure to introduce Dr. Mackenzie Salt, who's a postdoctoral fellow at the Offord Center for Child Studies and a member of the Autism Alliance of Canada. And he is an autism researcher and is finalizing work on the Canadian Autistic Adult Needs Assessment Survey, which involves over 1,900 respondents across Canada who are over the age of 30 years. So I turn it over to you, Terry, and your team. Thank you.
Thank you so much, Sue and team. We're so honored to be here. And we want to begin as well by giving honor and thanks to the Haudenosaunee and Anishinaabe nations as the traditional inhabitants of the land where McMaster stands, where we are. And to say that is to acknowledge a debt to those who were here before us and to recognize our responsibility as guests to respect and honor the intimate relationship Indigenous people have with this land. I want to acknowledge that we are the authors of this particular talk, and thanks to Public Health Ontario for hosting it. Represents the pathway of our humble learning that we're hoping to share today, keeping in mind that this is kind of our ethos as clinicians for Natalie and me. It also reminds me, pardon me, I'm having some. So this also reminds me of one of my favorite paths when I was a young camp doctor at Christie Lake Camp. This was a wonderful children's camp that had been directed for 40 years by our late research center director, Dr. Dan Offord. At the time, I was eager to impart my 29-year-old wisdom as a new child psychiatry resident. But in the end, mostly I learned by walking down the same paths that he did and talking to children. This one girl comes to mind in particular. I'll call her Krista. Krista was different from the others, content to be with her cabin, but not overly chatty. And most often she could be found lying on the ground observing beetles, blades of grass, and anthills up close and on her own. Every day she wore a quirky fedora, upon which was perched her camp pet, a caterpillar. I commented that day that I liked the hat, and she quickly told me that it was her dad's. She said he also liked to dress up every day, even in the summer. We dress the same, we talk the same, we even walk the same, people tell us, she reported proudly. We're two peas in a pod. Trying to think deeply as a child psychiatrist, I asked her, do you think the same way as your dad as well? And she looked up, stunned, and said, I am unique. Why would anyone think the same way as me? And then she shook her head as I lost all adult credibility, and she shuffled off to the swimming hole. Two things relate to that today in terms of our talk. First, we want to remind ourselves how precious is the bond between parents and kids, especially when the world does not always celebrate families who are different from other kids and grown-ups. And secondly, how important it is to remember, as we discuss neurodiversity, that everyone is unique. As a child psychiatrist, my field is very fond of diagnosing and categorizing. But today we're going to talk about tailoring our care to the dimensions that are related to folks' brains, but also to their relationships and their experiences, keeping in mind that each person is unique and requires a tailored approach to care. Which brings us to our agenda today. We'll be emphasizing, pardon me, sorry. Yes. We'll be emphasizing first that neurodiversity is diverse. It's important to understand some key cognitive domains. So our talk is going to be in three sections. First, we're going to discuss really that neurodiversity is diverse. We're going to describe some key cognitive and contextual domains, but we want to emphasize that the relative degree to which this is a strength or something that's challenging for people is going to vary from person to person. Where Natalie and Mackenzie, they're going to describe their work both at a national level and at a finer grained clinical level that really listens to neurodivergent parents' perspectives on healthcare, service, delivery, and parenting. And third, we're going to work to integrate all of this information to think about how we can really deepen the toolkits that many of this audience already have to create more compassionate, trusting, and strength-based models of parenting that are really tailored to people's neurodivergent profiles. Starting first, we're going to look at neurodiversity. And I'm going to give a few words, first of all, about some inclusive and strength-based language that Mackenzie and I are going to discuss. First of all, while we use the term parents and caregivers interchangeably somewhat throughout the talk, we want to acknowledge really clearly that many parents comprise kinship caregivers and other care providers and are not always biological parents. So we are, even in using the word parent, we are adopting a very broad lens that encompasses all caregivers to infants and children. And now I'll pass it over to Mackenzie.
Thank you, Terry. So I'm going to talk about a couple of things that we want you to know about language, and these apply to autism for sure, but they also apply to they can also apply to other neurodevelopmental conditions as well. So first of all, right now, when we look at language, there's this distinction between identity first and person first language. So for those of you who may not be aware, person first language is a grammatical construction that refers to someone as person first, followed by their condition, such as person with autism. This construction is quite controversial in the autistic community. The construction itself separates the person from the condition, but many autistic people feel that they are inseparable from their autism. So to separate one from their autism would be to have a completely different person. In the autistic community, identity first language or autistic person has been reported as a preferred construction by a majority of those surveyed about it across cultures and languages. So the citations are there in the footnote, and they'll be on our reference list as well at the end. Due to that preference, in this presentation, we'll be avoiding person first language and favoring identity first language. And in places, we will use a more neutral construction that is sometimes used of someone being on the spectrum. Also, for the last 30 or so years, at least in research, the research literature has referred to people with functioning labels, so that people who have significant challenges with day-to-day tasks were referred to as quote unquote low functioning. These labels are ones that are not acceptable in the autistic community. Autism is now classified diagnostically in levels based on the levels of support needed. But in common parlance, levels of support needs have arisen as an acceptable alternative to some people. Functioning labels have the connotation of deficiency and are not very helpful, as they lack specificity of where the person might need more help. And so when describing someone who might be considered low functioning as having a high level of support needs instead is more helpful and more respectful, because you can also specify that, saying they have higher support needs in a particular area or a set of areas. And this sort of construction is not saying that the person's lacking or deficient in any way, but that they just need more support to do things. And this leaves their autonomy more intact. And lastly, we want to focus on strength-based language. So rather than disorders and deficits, apart from clinical terms like autism spectrum disorder, we're not going to move away from that. But in general, we are going to replace words like disorder with ones like conditions, and deficits with differences, so that it's not as stigmatizing. Okay, and I also want to talk a little bit about what are neurodiversity and neurodivergence. So these are terms that are becoming more and more popular. So let's address what they are. So firstly, the term neurodiversity was coined by an autistic sociologist named Judy Singer in the late 1990s. And it refers to the idea that certain developmental disorders are normal variations in the brain. They're not problems to be fixed, but more akin to differences to be accepted. And it's important to note that just because neurodivergent people think differently, this doesn't mean that they do not face barriers in many aspects of society or otherwise need accommodation. A quick grammatical note, neurodiversity represents the idea or movement around this idea. And neurodivergent is a descriptor for a person, and neurodiverse is a descriptor for a community comprised of neurodivergent people. And lastly, the term neurotypical is one you might see, which can be a descriptor or it can be a noun, and it represents a person who is not neurodivergent. Okay, and next, Terry will be talking about specific neurodiversity profiles. Take it away, Terry.
The point of this slide is really just to emphasize that neurodivergent profiles are common. Although systematic review is lacking in many ways, in general, data from across Canada, the US, and globally indicate that about 15 to 20% of children, and then of course the adults that they grow up into, will experience some profile that can be connected to neurodiversity or neurodivergence. For example, about 2% of adults are considered to be on the autism spectrum. About 9% of kids, or about 3% of adults, may be diagnosed or diagnosable with attention deficit hyperactivity disorder. And prevalence rates for intellectual disability are around 0.5 to 1%. And it's also important to remember that many people will have challenges and strengths related to learning disabilities and communication disorders, which of course influences things like literacy, breaking down our instructions for folks. And so keeping this in mind, that a large chunk of people, of adults with whom we will work, will identify or may be identified as neurodivergent. And of course, this has particular implications for several ways. First, we're going to really stay away in this talk in referring to specific diagnoses overall, because 70% of these conditions co-occur. Furthermore, it's important to keep in mind that symptoms and impairment related to any symptoms can change over the course of someone's lifetime, even in the course of someone's adulthood. As practitioners who are supporting parents, one important piece to remember is that mental health co-occurrence is very high. Up to 70% of adults who identify as neurodivergent will also experience mental health challenges such as depression or anxiety. And so keeping an open mind and really a lens towards addressing this with them will be really important. And finally, children who identify as neurodivergent are more likely to experience psychosocial stressors. So the experience of adverse childhood experiences is going to be more common among adults who identify as neurodivergent as well. And again, with the work that so many folks do, this is something that we weave into our practice. So keeping in mind that lens of thinking also about context is so essential. When we do think about autism, though, some key domains, we're going to review now some key cognitive domains that influence our practice and how we provide care. We think about social communication as being a core cognitive set of functioning that relates to autism, but also to many other profiles. We can break this down into really three categories. The first is social reciprocity. When we're dealing with kids, this involves that back and forth play, back and forth engagement, shared engagement on a common focus, pointing at things. With adults, it involves often kind of that ease and back and forth conversation, such that we don't even really have to think about that. That's more challenging for some people. Nonverbal communication may also be different for some people. For little kids, this involves gestures and often body language. And for adults who are neurodivergent, this may mean expressing their emotions differently in the terms of a nonverbal way. Their facial expressions may not always line up with how they're feeling inside. And some people struggle to read the emotions and intentions of other people in terms of their nonverbal communication. And third, social communication comprises how we approach others socially, how we engage in relationships, how we maintain relationships such as friendships or coupleships, and how easy this comes to us as humans. And as Mackenzie said, thinking about tailoring that level of support, where does social communication need support in what domains for specific people with whom we're working? In addition to social communication, autism is associated with this behavioral and sensory profiles that are important to keep in mind. Many people who identify as autistic experience repetitive behaviors, either self-soothing or self-stimulating or other as part of their behavioral repertoire. Many folks will describe themselves as needing to really have a strong sense of routine, that change can be difficult, and being cognitively flexible can be something that can be harder for them. So needing things to be quite routine. Third, it's really important when we think about sensory sensitivity. So sometimes people are very sensitive to smells, to noises, to sounds. Others may describe that they're actually under-responsive or under-sensitive. And so these are key things when we think about the sensory symphony that is being a new parent that we're going to keep in mind. And then finally, some people who are neurodivergent or autistic will also describe having very strong interests that are maybe out of the norm in terms of their intensity or their focus compared to other people. And this, again, this can be a strength that we can leverage as well. It's important to think about if someone identifies as autistic, that about half of people also have some degree of language impairment. Intellectual disability is often co-occurring, but not always, of course, and mental health challenges, as I said. And finally, many people who are autistic describe themselves as having challenges with daily living and adaptive skills. This is part of the profile for many people, as is executive functioning, that capacity to plan, to switch, to shift off of certain ideas or areas of focus. These can be areas that are challenge for people with whom we work. And now I'm going to be passing it over to Natalie.
Another area of neurodiversity are intellectual disabilities. So intellectual disabilities are differences that are characterized by limitations in intellectual functioning and adaptive functioning. This begins in the early developmental period, and this would be usually diagnosed by formal testing, such as IQ testing and adaptive functioning assessments. So by intellectual functioning, we mean what might also be called intelligence. And this refers to abilities like learning, reasoning, problem solving, and so on. So for example, for adults trying to learn a new concept or process. And adaptive behavior is the collection of concepts, social skills, and practical skills that are learned and performed by people in their everyday lives. So things we would call conceptual skills would be things like language and how to use money and how to kind of measure and tell time, etc. As well as social skills, so interpersonal skills, self-esteem, and the ability to follow rules and obey laws, but also to avoid being victimized. Also, this would encompass practical skills, so activities of daily living and personal care, occupational skills, so things that one would need to do for a job, travel and transportation skills, following schedules and routine, using the phone, etc. The things that are necessary for independent living. Another area that is a key area of neurodiversity is ADHD, or attention deficit hyperactivity disorder. In those with ADHD, the key difference, again, as Terry mentioned, is with executive functioning, which underlie these symptoms and cut across many other profiles. So in adults, challenges with inattention and focus might look like problems with organizing tasks, activities, and managing time, losing things like keys, wallets, and phones, being distracted by unrelated thoughts, and being forgetful in daily activities, things like paying bills and keeping appointments, or even returning calls. Challenges in hyperactivity and impulsivity in adults with ADHD might look like a lot of restlessness, difficulty sitting still, and maybe even wearing others out with one's activity. Could be answering questions before they're asked completely, interrupting or intruding on others, and can lead to difficulties regulating mood, which is really important because if a parent with ADHD also has a child with ADHD, there is a higher likelihood of family conflict and hostility. Adults living with ADHD can often face challenges managing their everyday lives. They may have difficulties with organization, job stability, and keeping appointments. Routine activities like waking up, getting ready for work, and being punctual and productive at their job can be quite taxing for those with untreated or undiagnosed ADHD. They may have a history of struggles in academic realms, professional realms, and relationships, which is important to understand. And they may have a tendency to multitask with limited success. And they might also favor immediate solutions over more comprehensive strategies that offer long-term benefits, and overall are at higher risk for mental health symptoms. So to review, we have summarized some key domains of difference in neurodiversity. Individuals may experience challenges in understanding and using language and nonverbal cues, and this affects things like social interaction and communication. Many neurodivergent individuals also have heightened or reduced sensitivity to sensory inputs, which can absolutely affect their daily life, making certain environments, especially the home environment, overwhelming or understimulating. Difficulties with planning, organization, and adapting to change are common. A structured routine and familiarity can provide comfort and improve functioning. Managing and expressing emotions can be challenging. This may result in unique coping mechanisms and requires understanding and support from people in their lives. It's important to remember that neurodivergence manifests differently in each individual. Embracing this diversity is key to providing inclusive support. Mental health issues often co-occur with neurodivergent profiles. It's important to address these in conjunction with neurodivergent traits for holistic care. And the social and psychological environment plays a significant role in the well-being of neurodivergent individuals. Supportive and understanding communities can greatly enhance quality of life. And now I will turn it over to Mackenzie.
Thank you very much, Natalie. Pardon me. So for this section of the presentation, I'm going to start talking about perspectives of neurodivergent parents, and my information comes from the Canadian Autistic Adult Needs Assessment Survey, which was over 1,900 autistic adults age 30 plus. That was done just this past summer. And then Natalie will be talking about information and perspectives that come from some quality improvement and other research reports. Okay, so there were several themes that came up in the Canadian Autistic Adult Needs Assessment Survey from autistic parents around various topics, and I'm just going to address a few of them here. First of all was legal. So the survey was not only for people with a diagnosis, it was also for people who had not had a diagnosis but self-identified as autistic, and many of those people spoke about potential legal issues, that particularly that they're concerned that if they got an autism diagnosis, they had worries about losing their children or other rights. So these two quotes here are from survey responses. I'm trying to raise two autistic boys on my own who have been abused, and the abuse continues because we're in our family law system there is a checkbox that says one parent is autistic, but still good, loving, capable, does all the work, all the drives, pays for it all, works 2 jobs. The moment I input a disability, my abusive ex has control of the children in spite of his criminal history. I have concerns I could compromise my ability to go to certain countries, or that it could be used against me in regards to parental rights. So for these people, they don't want to seek a diagnosis because they have very strong concerns about their ability to be a parent, to foster children, and for mobility. And another common theme is medical discrimination, where people feeling like they're dismissed or not heard by medical professionals. And this is particularly an issue for people who've been misdiagnosed or diagnosed late, which being diagnosed late is very common for autistic women. So examples here being, when I accessed healthcare for other things, such as pregnancy and childbirth, dentistry, I'm selective about disclosing autism because I don't want my agency to be diminished by an ignorant or biased practitioner. I feel that the last psychiatrist I was seeing didn't listen to me. I struggled to communicate what was happening in my head and felt dismissed, and that their agenda was to get me onto a specific medication that I was on in the past and was no longer effective. As Natalie mentioned earlier, many autistic people can be hyper or hyposensitive to various stimuli. In this case, we actually had 3 people who responded in the survey that their sensitivity to odors either increased or they gained a new sensitivity to odors when they were pregnant, and that this persisted after the fact as well. And then in terms of general parenting, I'm not going to go, in the interest of time, I'm not going to go through all the quotes, but they are here that you can reference. And when the recording is posted, you'll be able to go through them there. In terms of general parenting, there were challenges of balancing multiple levels of need in the same household, such as lack of resources, or issues such as disclosure. Like, how do we explain to our children that that were autistic, or managing a household with multiple neurodivergent people who have different levels of need. Domestic help is a very common response that we found from autistic parents in terms of challenges. So in this case, I tend to forget to make food or do not have spoons to cook food for myself. So having someone else cook for me is often required. And I want to explain what is meant by spoons. So they don't mean the physical utensil of a spoon. This is a common metaphor in the disability and chronic pain communities that refers to finite units of energy. So someone might have 12 spoons on an average day that they can spend, and maybe making dinner is 3 spoons, maybe showering is 2 spoons. It depends on the person and what they're going through and their individual levels of energy. So if they're having a very bad chronic pain day, they might only have 6 spoons to work with for the rest of the day. So they have to prioritize. So that's what this person means by spoons. And then respite, so needing a break from the children and dealing with household chores. And this was a common request in another survey I did around the needs of caregivers and autistic adults during the pandemic, was the need for respite. So very common concern. And then lastly, I want to address 2 other themes that came up that were particularly important. Feeling left behind. So the first quote here epitomizes it. We need to address giving support for families of autistic children, especially as one of the parents has a high probability of being ASD or autism spectrum disorder as well. So we had responses from people who there were supports for their children, but there were no supports or resources for them. And in some cases, they were putting their children first and they were supporting their children, but they were suffering, their mental health was suffering because they had no support. In other cases, they're putting off their own needs and also waiting for supports to help their children. And lastly, I wanted to address some tips for giving information to autistic adults. So first of all, listen to them. They will have things to tell you and they want to be heard. I'll also ask them what they need and how they best understand things. They're the experts. They know how they best process information and how they want to be told things. Some autistic people can find certain media better for receiving certain types of information. They might want some things written down. They might want to do things over the phone. They might want things delivered in sort of short bites to help them process. It's all very individual on what they need. And if you're trying to convey something particularly important, make sure to ask for understanding, but also be willing to repeat or rephrase potentially multiple times. An autistic person might need to hear something, especially if it's really important or really emotionally charged. They may need to hear it several times in several different ways to really help them process. But again, ask them what they need and what can be helpful to them, and give them time to formulate responses or process. I'm guilty of this in some of my interactions with people. I'll get some information and then I'll say, okay, yes, I understand. But then maybe 2 minutes later, I'll have a really urgent question about what I was told that I didn't think of at the time. And then I sort of have to go back. And then be prepared for follow-up questions, but be very careful about preempting them. So if after explaining what you're trying to convey, you immediately follow up with something like, you're probably thinking what to do about X, that person might get defensive or be insulted by you saying that you know what they're thinking, and they might still be processing what you've told them. And if you get it wrong, your assumption of what they're thinking, that can sort of say to them indirectly that you know better than they do what they should be asking, which is really condescending. So overall, you need to be understanding, patient, and treat autistic adults with respect in your interactions. So I will pass it over to Natalie, who will speak specifically to work with intellectually disabled adults.
So in our work as child psychiatrists, Terry and I work with a lot of parents. In children's mental health specifically, parent interventions are actually the mainstay of psychotherapeutic treatments for young children. So we were beginning to learn from neurodivergent parents whom we were working with that when their children required family-focused mental health services, parents were experiencing their own neurodivergence, specifically intellectual and developmental disability, as a barrier to engaging in their children's care. Parents were telling us that they were struggling to fully engage with in their child's mental health care, which can itself be associated with poorer mental health outcomes for their children. So Terry and I undertook a continuous quality improvement, or CQI, approach to explore the accessibility of family-focused mental health services in our child and youth mental health program, specifically through the lens of parents who identified as having intellectual and developmental disabilities. We collected data from conversations with parents who identified as having intellectual and developmental disabilities during clinical assessments, focus groups with mental health clinicians, and a survey distributed to mental health clinicians and interviews with clinical educators. The general themes that emerged as barriers for neurodivergent parents were difficulty understanding the process for accessing treatment, difficulty understanding the content of family-focused treatment, feeling that our intakes were too long, and difficulty sharing or defending new concepts to adults in their lives. Themes that emerged as potential strategies for improving access for neurodivergent parents themselves were tailoring the way content is delivered, providing these families with much more individualized support, actually leveraging the clinician that they were working with as an advocate for the parents, and also helping parents to leverage the people in their communities, like grandparents or support people, who could actually be a part of the conversations that we were having, and providing material support to parents where possible. So taking care of things like parking or bus tickets, so that is one less thing for these parents to have to worry about. Some tips that arose from the data, again from neurodivergent parents themselves, were using role playing. So things like modeling responses, especially nonverbal responses, giving very specific examples, avoiding generalizing, using videos and visuals wherever we could, and trying to avoid relying too much on reading, avoiding jargon, simplifying language, and overall keeping our sessions super brief. This is all really important because when children, especially young ones, need mental health care and supports, family-focused treatments are the best treatment that we have. It's been so helpful for us to understand what we were missing when we were engaging neurodivergent parents and how we could modify our approach. I hope some of these findings can be strategies that you as nurses can use to create a psychologically safe home visiting environment for parents who are neurodiverse. And hopefully some strategies can be used to address some of the common challenges that you might face. And I'll hand it over to Terry.
Pulling it all together now, we're going to talk about thinking about developmental ecological models of care. And I think I'm preaching to the choir, of course, here. This is an approach that's really derived from the family checkup model, which is early prevention and targeted intervention, family-centered model of care that we use at the Ron Joyce Center. And really, the principles are that when we're thinking about working with any families, and thinking in this case about neurodivergent families, how important it is to be strength-based. When you're thinking about how the parent with whom you're working self-identifies as neurodivergent, we're laser focused on how can we support this parent to leverage their unique strengths. We want to think about being assessment driven and collaborative as much as possible. So using data where we can, but particularly that self-assessment piece. What is it like for parents who are neurodivergent? What strengths do they bring to their family? What do they find challenging? How can we come up with a plan together that's tailored to their needs? And thinking about that being self-assessment, it's asking about all of those neurodivergent profiles, different ways of thinking that we described, but also their relationships, of course, within their family, and their place within larger society and culture, which is often not, which often has very entrenched ideas of disability and inclusivity. And finally, we want to think about a motivational approach. And I'm going to speak to this next. This is something that I think has been reviewed at previous sessions, and there is some guidance as well online on the website. So I'm going to review some principles called ORs, the ORs of motivational interviewing with respect specifically to neurodivergent caregivers. So for those of you who've been at the session before, for the ORs session, you may recall that OR stands for open-ended questions, affirmation, reflection, and summarizing. So when when people self-identify as neurodivergent, or whether you suspect that, as Mackenzie and Natalie mentioned, there can be a lot of stigma around this. Really, the importance of open-ended questions is so essential, with follow-up, careful follow-up, as Mackenzie was describing, as needed. So open-ended questions really draw out and explore people's experiences, their perspectives as a caregiver, and their ideas. This involves first eliciting. Ask them what they already know. What is their experience of parenting? What is their experience of being a neurodivergent adult? How do those intersect? Ask permission, to provide information about parenting from your area of expertise. They have an area of expertise, and can you ask permission to provide what you know about the topic that you're discussing? And then elicit, explore how is that landing with them? How is that information providing sounding to them? Here's an example. You mentioned that sometimes you find it hard to read others' emotions. Have you found this with little Frankie? And then providing, that's a worry a lot of us can have with our first babies. Can I share a tip? And finally, checking back in. What would it be like for you to try this with Frankie? What would be easy for you? What would be hard for you? And so that's tailoring it to social communication. A is affirmation, which again, thinking back to that level of stigma that people often feel that if they disclose any facet of neurodiversity to the person with whom they're working, that's already going to put them in a place of feeling judged. It is so important to affirm people's strengths, their efforts, any efforts at collaboration, and past successes that they've had as human beings and as parents. It really provides the foundation to help build hope and confidence and ability to change. And it reminds ourselves as clinicians, and this is really key, to look for the strengths of neurodivergent folks in child rearing. For example, as someone who's a pretty conventional person, I have learned so much from working with parents who are not nearly as conformist as I am around creative family problem solving, making the most of your child's unique skills. I really rely on a lot of parents to understand what their special family culture is like. Some examples of affirmation include, I appreciate that you're willing to meet with me today. That took some real trust given your past experiences. You're clearly connecting with Jeremy's need to be his own person. So often neurodivergent parents are so much stronger at recognizing and celebrating their child's unique differences. Another one is like, you learned really hard, some hard lessons about camouflaging and what that's like as an autistic woman. And now you want to help your kids be proud of their uniqueness. And camouflaging can be this experience that autistic adults describe in terms of having to hide their autism. And finally, you reached out for help in the past, even though that's been hard for you. Moving to reflections, this is based on careful listening. And I learned from talking with Mackenzie about this, that it's very important, very often when we're reflecting back, we'll repeat verbatim, a simple reflection back to people. We want to be really careful with our reflections to get a sense of how that's landing. Again, sometimes because of social communication differences or nonverbal differences, when we're really kind of reading into people's body language, we want to be careful and tailor our reflections to the person with whom we've built that relationship. But it's foundational to how we express empathy. We want to be mindful of how it lands with others. For example, it sounds like you want help from your mother, but you also want to respect that you're a mom too. And so you want to feel in charge. And so these other terms like, so you're feeling, you're wondering if. We want to use them when we know the person well, and be cautious if we don't know the person well, to be careful that we're not looking like we're assuming what they're thinking or feeling. And finally, summarizing. As Natalie and Mackenzie have described, this is particularly essential when you're working with someone who may have challenges with executive function, so working memory, recall, organizing strategies, or also other kinds of challenges. So it ensures that the session that you just had, that little chunk, is understood, and really you're reinforcing the points made by the client, again, building self-efficacy. Consider building in multiple media, leaving summary sheets, using images as you need to. So let me see if I understand. Here's what I've heard. You tell me if I've missed anything. So these are just some of the ways of summarizing and integrating what we've talked about with respect to some neurodivergent profiles with many of the skills that you already have. Keeping in mind, we are always thinking not only about how that person's neurodivergent profile, whether they're self-identifying or they're diagnosed, relates to their experience of parenting, but also their mental health, thinking carefully about their relationships and supports in parenting, all of those key pieces that in public health nursing and home visiting you're so attuned to, thinking about power relationships and dynamics, and really thinking about socioeconomic well-being, cultural and family and other supports. I'm thinking always about social isolation as well. So really that developmental ecological approach. So we want to thank you all for listening. We want to remember neurodiversity is diverse. These are not about boxes or categories, but really about being open to hearing about the experience of neurodivergent people. Keep in mind some of the key cognitive and contextual domains, and we will provide these in a tip sheet with some more specifics. Ask about neurodivergent parents' perspectives. What have things been like for them before? How would they like things to be different in your relationship with them? And bake all of this information into a more open and trusting and strength-based model. These are the tools that so many of our audience members already have. And so just thinking about tailoring them a little bit is really kind of the bottom line that we want to emphasize. Thank you everyone for listening. Thanks to the families and kids that with whom we've worked, as well as our advisory committees and the funders for our various projects. And we're happy to take questions now. Thanks so much.
Great. Terry, Mackenzie, and Natalie, thank you so much. And I'm so thrilled that we have about 10 minutes for questions. And I see they're coming in the Q&A. And if anyone else has a question, please pop it into the Q&A. We'll try to get to as many as possible. Now, you spoke about social reciprocity, and in the types of assessments that public health nurses engage in with families, and then the interventions that they deliver, there is some work where nurses encourage families to have FaceTime with infants, to read babies' cues. And if a nurse identifies now that they're working with a parent who has challenges in engaging in social reciprocity with their infant, or doing FaceTime or talking, or that playing with a baby, are there any strategies that you can recommend that how a nurse can support that parent to understand the importance of FaceTime, social reciprocity, and reading babies' cues?
I can take this one. Is that okay, Mackenzie, Natalie? Yeah, no, thanks. That's such a key piece, and we will include some guidance, some of these tips as well in our sheet. But there's an interesting study that looked at new moms and looked at the infancy period, and we have it in our reference list. A couple of things. First, one thing that in Mackenzie's work, and also in the broader research on, for example, autistic parents, is that it's so important to provide the rationale. Very often we skip the rationale, but what many parents described in these studies is that they weigh, essentially, thinking about this idea of spoons that Mackenzie brought up, which I hadn't learned before, which was so helpful. If they're going to put a lot of energy into something, they want to understand the rationale. So make sure the rationale is so clear and not assumed. And then it may take more energy and more work and more attention. So that is something that explaining really the importance is that one key piece, not to assume. Also, not to assume that this is not something that autistic or neurodivergent parents can do. So many people, this is a strength of theirs and they will work extra hard at it. So not to make assumptions that because someone identifies as autistic that this will be a challenge is another piece, of course. And then really emphasizing, as Natalie said, a lot of role play, a lot of extra role play, a lot of strength-based feedback, really, when possible, supporting their autonomy, being very careful about what are there certain pieces, again, that tailoring, for example, that they may like if they've got a grandparent, would they like the grandparent involved around that so that they can continue to work and help with them, but checking first so as not to undermine their autonomy. But some of the tips from these parents in these studies included really just extra practice around that. So again, not terribly different from what we do, but extra practice, and maybe also support around scheduling that FaceTime. It may be something, again, with that reference back to the idea of spoons, this is going to be a big piece during this period of time. What can we take off the plate so that this can be a focus?
Oh, excellent strategies. I suspect there's many clinicians and nurses out there writing many of those down. And in a similar vein, another question around recognizing and appreciating that some of the young parents or parents that nurses may work with, if they have ADHD or ADD and have some challenges with executive functioning around organization. A common challenge in home visiting practice is canceled visits, missed visits, no one being home at the scheduled time, disengaging during the home visit. Any recommendations on how nurses can sensitively manage, or not manage, but address these common issues in home visiting practice?
Thanks. Natalie, do you want to take this one? This is something I think that you worked with in our clinic.
Definitely. One of the themes that came up was lots of reminders and kind of, again, leveraging the clinician as an advocate. So trying to work with parents to determine, like, what is the schedule that works for you? Like, are there times of day that are generally not great? Can we avoid those? Also, sometimes one of the really common or one of the themes that came up a lot was actually parents having a hard time talking on the phone, like the phone itself being a really hard method of communication, or anxiety about picking up the phone. So identifying, is there someone else that they're really close with, like a parent or a grandparent, who can field those phone calls and then communicate it? Can we be communicating by text if that's easier? So again, it's a very individualized approach, and lots of reminders and figuring out the medium and the method that kind of works for the individual parent. And then when it comes to things like zoning out, I think or zoning out, or having a hard time focusing, some of the strategies that came up as being really helpful was, again, keeping sessions really brief. So we're going to talk about this for 5 minutes, and then we can move on to something else, and kind of setting those parameters, and also really trying to engage. So it's not just delivery of information, but can we role play this a little bit? Can we practice it? So it's not just, us kind of spewing a whole bunch of information at the parent. So those were some of the strategies that we found really helpful, especially for parents who said they struggled with anxiety in the context of executive functioning difficulties.
Great, thanks, Natalie. Now, another question that's come up, do you know of any conference or summit for professionals on neurodiversity autism regarding topics like new approaches or strategies that are Canadian based? Because this individual says they've only found ones in the US.
Mackenzie, do you have any? Sounds like
yeah. So I'll say it outright. So as I'm affiliated with Autism Alliance of Canada, I take that in mind with what you will. But the Autism Alliance of Canada does do a national leadership summit that does include inclusive training sessions. So periodically. So it deals with autism policy, but it also has sessions about, we had one last year on housing and post-secondary education and sort of working groups on those issues. So that is one that I know of off the top of my head because of my affiliation with them. I'm sure there are a few others, but none of them pop up off the top of my head right now.
Great, thank you. And one of our attendees also identified that Holland Bloorview Autism Summit in 2022 was an amazing conference. Hopefully that there will be another one. Okay. Oh, sorry, go ahead.
One piece as well. It's worth always checking out the Kids Brain Health Network has an annual conference, and it's about family-centered. It's a strong focus on family-centered care, and so depending on the offerings in a given year, they may also. So Kids Brain Health Network.
Great, thank you. Given the issues around stigma and individuals' different experiences in medical situations, legal situations, there's two questions I'm going to combine here, and it's both questions are about strategies on supporting parents on how to disclose their identity as an autistic adult, or strategies on when and how parents might choose to disclose the identity of their child to different systems, given the challenges that you identified. So I guess the question, I combined two questions. Yeah, you know, how to disclose or discuss identity or diagnoses with different systems.
Can I take this one?
That'd be great. Thank you, Mackenzie.
Okay. Okay, great. So I've gone through this process a number of times. When I was first diagnosed, I was 13, and I didn't really tell anybody. I didn't really understand all of the implications and things about it at the time. But I've found personally that self-advocacy is very helpful. In workplaces, and I did mention that in the Q&A, I did respond to one of those questions about workplace disclosure. It can be very helpful to, rather than just saying I'm autistic and walk out the door, it can be very helpful to describe, okay, what does that mean? So what does that mean for the workplace? What does that mean for the professor for the course you're taking? What does that mean for the doctor? Like, how does that affect how your care will be changed? Because just giving someone documents about autism covers a whole wide variety of things, and because autism is so heterogeneous, it's sort of, okay, which of these things apply to you? So it's about a personal level of comfort and also trust with the people you're dealing with. If in a workplace situation, you might want to include HR. There's certain legal requirements to accommodate. So there's that, and in education as well, there are disability accommodation requirements. So it's really about trust, and it's really about the person's level of comfort. If they feel uncomfortable, if they want to bring someone to help them get through that process, that can be helpful. But I think rather than just saying I'm autistic, sort of also coming through with, this is autistic and this is what it means for me, I think is very helpful.
Great.
Thanks. I was going to add quickly, sometimes I find it really helpful around like doing assertiveness practice with folks. And again, coming back to like role playing, if that's a key piece for a parent, and it can be occupationally. So that might be something, practicing all of those things that Mackenzie mentioned.
Great. My goodness. Now I look at the time and I see we have 1 minute to 10:30, and there still are many other questions. So I apologize that we're not able to get to everybody's questions today. But Terry and Natalie and Mackenzie, thank you so much for sharing your wisdom, your lived experiences, your professional expertise with everyone today. Right at the beginning, I was so struck with the qualitative quotes. Thank you, Mackenzie. I am a qualitative researcher through and through. But sharing those lived experiences of the adults in your study really resonated with me. And I think it's so critical for clinicians to hear those alternate or different perspectives, so that we can start to have, I don't want to say walk in someone else's shoes, but a new understanding of what others' diverse experiences are like. And so thank you for sharing those. And the strategies that all of you have shared will be very helpful and in alignment with clinicians' practice of delivering trauma and violence-informed care, care that builds capacity and that is strengths-based. So I would like to thank all of you for joining us today. A reminder to all the participants that you will receive a brief and anonymous survey for today's session. And please try to complete the survey. It helps both PHN Prep in identifying topics and Public Health Ontario in improving programming. I want to highlight for everyone that in January, our next webinar will be January 17th, 2024, and the topic will be cultural humility in home visiting practice. And I'm very excited that one of our local public health nurses, Amina Alizi, will be our speaker. And lastly, just to confirm that this presentation has been recorded and it will be archived within a few weeks, both on the Public Health Ontario website as well as on the events page with PHN Prep. So I'd like to thank all of you for joining us. Thank you again for Sarah for co-moderating, and thank you to our speakers, and wishing everyone peace and joy over the next month. Thank you, everyone. Have a good day.